Good
All
for you.
right.
Thank you, Katrina.
Sure. All right. So our objectives today, I'm going to give an introduction of what occupational therapy is, and then we'll discuss some treatment approaches for people with Parkinson's disease. What does Parkinson's disease rehabilitation mean? So when does that happen? What does it look like? How do we do it? And what does a team-based rehabilitation care look like across the stages of Parkinson's disease? So this is where Anuja and I will share from our background how we can co-treat, and then we'll have time for a Q&A. So a little disclaimer, any products or examples we use, we're not promoting. They're just there to illustrate a concept or an option. So what is occupational therapy? A lot of things come to mind. The next couple of slides are just some screenshots from our practice framework, which guides our practice. So I'll give you a definition from our American OT Association. Basically, occupational therapists focus on things that you want and need to do in your daily life. So occupational therapy interventions use everyday life activity, and that's what we refer to as occupations, to promote health, well-being, and your ability to participate in the important activities of your life. So these include meaningful activity that a person wants to accomplish, including taking care of yourself, your family, maybe working, volunteering, going to school, among many others.
Do you
So
think
in our
we could...
framework,
Oh, sorry to interrupt. I was thinking we could do maybe a poll to see who in the audience has actually tried occupational therapy, to see if they've tried it a lot, some, a little, or not at all.
That's a great poll.
Yeah, let's do that one, Kathy, and then right after that, you can do the physical therapy one.
Okay, yeah, so we'll do both of those polls just to get a sense of, you know, who's tried occupational therapy and physical therapy.
Perfect, but you can keep going, Katrina.
Okay, great. So in our practice framework, we have our occupations. So those are activities of daily living. Health management is considered an occupation. That's why I have it highlighted, because I'm going to cover a bunch of examples as it relates to Parkinson's disease. Rest and sleep is important. Education, so is play and social and leisure activities. As OTs, we consider the context. So what are the environmental factors? What are your personal factors? We also consider your habits, routines, your roles. Then we look at your performance skills. So we do assessments to take into consideration your motor skills, your process skills, even social interaction. And then we look at your client factors. So what do you value? What do you believe? And how does your body function structure? Because everyone is different. So, oops. Trying to progress my slide. There we go. So health management, what does that mean? So anything that's related to managing, developing, and maintaining your health and wellness routine. So as you can imagine with Parkinson's, there are a lot of things that you do to manage your health, right? You're communicating with the healthcare system, you're monitoring your symptoms, there's the emotional aspect. Along with that, we're looking at medication management, nutrition, and then if you have any personal care devices, managing that. And then I have highlighted physical activity because we're going to talk about how that's such an important role in Parkinson's disease. So when we think about treatment approaches, you know, what's the best one, right? We all want to know what the best one is. But when we look at them all, it's really a multidisciplinary approach is the best one, because it provides us that holistic perspective. So this is why it's so important to have your neurologist and your OT and your PT and your speech, to consider your diet, your exercise, and psychology. So when we think about occupational therapy principles, the first principle is early intervention. And we want that because we want to prevent any loss and restriction to your roles or activities. We also are client-centered, so we do assessments on individuals to see what is it that needs the most attention right now. We develop goals in collaboration with you and your caregiver, and then we regularly review to see if those goals are being met. And then finally, we're trying to enhance participation in everyday activities by addressing any challenges you're facing, whether they're psychosocial or physical. So when we look at Parkinson's disease in particular, there are a variety of OT interventions that we use to address your skills, your knowledge, and your attitudes to support you and your caregivers. So the first one is that we would set a goal, we'd identify it and set it collaboratively. So we regard you as an expert in your own life. Then we analyze your activity. We break down the task. We look at the quality of your performance, the amount of effort you put into it, your efficiency, what's your own satisfaction on that performance. We assess any other services or resources that you might be using. And then we look at what is your attitude level on your performance? What is your knowledge level on the intervention that's supporting your performance? And then finally, what's your skill level to enhance that performance? And so again, this can look very differently depending on what it is that you want to work on and what your strengths are. So when we look at OT specific interventions, the most commonly used ones are categorized into these three. So number one is exercise or physical activity. The second one is environmental cues, stimuli, or use of objects. And the third one is self-management of cognitive behavioral strategies. So Anuja and I are going to go into some examples of each of these as we continue. So now when we think about that rehabilitation team, what is that? Well, evidence supports that you should engage in OT, PT, and speech soon after diagnosis for the best outcomes, and also in response to any functional deficits. So there are different levels of how this looks when you start a rehabilitation program. So the first one would be considered consultative proactive rehabilitation. So again, this is soon after being diagnosed, and you're assessed and you're treated early on for any early deficits. And then there's that promotion of meaningful activities because we want to keep you engaged. The second one is restorative rehabilitation, and this is to promote functional improvements. And then the third level is what we call skilled maintenance rehabilitation. And this is for long-term monitoring of exercise, meaningful activities, safety, contractures, skin integrity, positioning, swallowing, and communication. So again, it's that interdisciplinary team that would be addressing all these together. So when we consider the stages, we have the stages of PD in its simple form. We have early stage, mid stage, and late stage. And it's going to look a little different at each stage as to what your therapist is going to be addressing and the frequency of when you would see them. So in the early stage, that's when we'd be doing the consultative proactive therapy. You would see your PT or OT, maybe 1 to 4 visits. And with 6 to 12 months, you might have a re-evaluation. So it's not as frequent. And then in this mid stage, you might be doing restorative therapy. And so there you might be doing 2 to 4 visits a week for more than 4 weeks. And then in the late stage, this is what we would call skilled maintenance. And you would do 1 visit about every 1 to 3 months ongoing. Okay, so when we look at that, I want to go back to this paradigm shift. Of course, all of you all are here because you are actively participating in management of your disease. You're seeking out resources, you're educating, and that's great. And this is reflective of what we're seeing is the shift from the passive patient model to an active participant. And this is really where you're going to get the best outcomes in your disease management. So I encourage you to be that self-advocate. And the therapist will help you in supporting you in your self-determination and your belief in your ability to be successful. So as we go through different examples of OT and PT interventions, we're going to refer to the stage of Parkinson's disease. The most commonly used classification system is called Hoehn and Yahr. It's simply a 5-level rating system that's based upon motor performance. So we all know that Parkinson's is more than just a motor condition, right? There are non-motor symptoms as well. But for the purpose of this demonstration, we're going to be referring to this classification system. So we'll go into each one. And I also want to note here that not everyone progresses through all 5 stages of Parkinson's disease. Okay, so we all know in Parkinson's, we have those non-motor and motor symptoms, and those impact your performance and participation. So the occupational therapist interventions will be addressing those symptoms and then hopefully impacting your performance and your participation. That's what it looks like in its simplified essence. So now it's stage 1. This is when someone might have slight tremors on one side of the body. Symptoms are often mild. You might have some changes in walking and posture. And the focus here in intervention, again, we're at that consultative proactive therapy. So here we're just focusing on promoting your health and educating you. Note that Parkinson's disease does not cause muscular weakness. It's really, that is the result of deconditioning from being inactive. So that's why at this stage, we're trying to produce a lifestyle of conditioning to help disrupt that progression of PD-related impairments. So we're paying attention to your current strength, your flexibility, your balance, your endurance. We're trying to optimize that functional performance capacity. We're going to look at your roles and habits and routines and orient them to a healthy lifestyle. And then, like I mentioned before, we're going to do goal setting. What are goals that are unique to you and specific to you?
So utilizing general exercise guidelines is really helpful to create this healthy lifestyle habit early on. So many times people feel like they're getting lots of exercise, but they may only be focusing on one aspect of exercise, like cardio or stretching, for example. But you want to have a well-rounded exercise routine to help your muscles and your body maintain that high level of performance. And it might also be beneficial to utilize an external like step counter or an activity tracker to help you track your exercise and make you have some accountability. So meeting with a physical or occupational therapist to help you with this and help you kind of create this exercise program for yourself in the early stages is something that you might want to consider. So this is a really nice graphic from a study by Quinn and Long that shows these 4 components of an exercise routine that we would recommend that you have in your routine. And there's various examples of exercises in each category. So the first is aerobic exercise, and that's really important for you to increase your heart rate and your blood flow to your muscle. It's also shown to improve your balance and your walking patterns for people who have Parkinson's. So some recent studies have also shown an improvement in your cognitive function when you incorporate aerobic exercise in your routine. And then the second category is resistance training. So that's also known to improve balance, muscle strength, endurance, and again, cognitive function. And it's also vital in improving or maintaining that more upright posture that will also help you with your breathing in people who have Parkinson's. And then the third category is stretching or flexibility, which can help address the rigidity that's associated with Parkinson's. It helps you maintain that range of motion, again, improves the blood flow to your muscles, and it allows your muscles to work at their optimal level of function. And then this in turn will help you utilize those balance reactions and improve the speed of your muscle activation. And then lastly, you want to make sure to have a balanced training regimen in your exercise routine, and it should ideally involve challenge, and that's beneficial in improving your coordination and reducing the risk of falls.
So Anuja, I think this is really important because if anybody else is out there like me that's been thinking that the prescription for us people with Parkinson's is mostly around aerobic cardio exercise, I never would have thought, for example, that weights are going to be beneficial to helping me with, balance and the like. So I think this is valuable for us all to know that we need to have a good spread of different types of exercises.
Exactly.
And on that note, I just launched a poll about your challenges. And so go ahead and let's see what kind of challenges people have in the group. Typing or gait, posture, self-care, those kinds of things.
Thanks, Kathy. Go ahead, Anuja.
All right. So yeah, as Anuja was referring to, exercise is a disease modifier.
You can choose one of these. You can't choose 3.
I think we just have to, everyone mute yourself.
Carry on, I'll mute. Go ahead.
Okay. Yeah, so exercise is a disease modifier, particularly when
Katrina, I think you're muted.
Whoops. Okay, thanks. Anyway, what I was saying was with exercise in particular, when we have aerobic exercise, we're getting your heart rate into a target heart rate zone that's been calculated for you, ideally in coordination with your therapist. And we pair that with a goal-based exercise. We see improvements in brain health. So we have an increase in blood flow, neurotrophic factors, neurogenesis, metabolism. We also see an increase in synaptic strength, so neurotransmitter receptor density. And then ultimately, this supports the strength and circuitry of your brain. And that leads to improved behavior. We see it in motor, cognition, mood, and motivation. So it's really encouraging, inspiring to see that the exercise we engage in can have an impact. So, Anuja.
So the great thing is that there are tons of PD specific activity programs out there for you. LSVT Big and Power are both programs focusing on large amplitude functional movements that are also working on specific goals related to each person's function. So they both have websites that have a directory of therapists who are certified, and you can find them based on your area. They aren't necessarily like some of them might have a shorter term session, but it's still something to look at and see if that's right for you. Rocksteady Boxing involves flexibility, aerobic exercise, strength training, and coordination training. It's great. They have, I think, over 900 locations all over the country. So, and you can look up if they have something in your area on their website as well. Dance for PD offers specialized dance classes for people who have PD, and it utilizes music to incorporate balance, coordination, and aerobic exercise. And it's also a great way to get social with your community. And then for those of you who might not have the resources to go in person or prefer to do things at home, there are a lot of online options. YouTube offers a plethora of Parkinson's related exercise classes for free. And the Parkinson's Foundation has a YouTube channel, and they have Fun Fitness Fridays, as well as other informational videos for you. So you ideally want to find a community program near you so that you're connected with other people who have Parkinson's, but you don't also necessarily have to go to a Parkinson's specific activity program. If you don't have anything like this in your area, going to any kind of exercise related class that helps you to socialize with others and also gets you a personalized experience for exercise is beneficial.
Excellent. So exercise, making a behavior change. Some of you may have a history of being active and engaged, and other of you, maybe don't have a history of being active and engaged in exercise. So sometimes it can be hard to make that behavior change. So your OT can help you with that, and utilizing a number of behavioral training elements such as education, again, setting goals that can be really helpful, setting SMART goals that are specific, measurable, attainable, realistic, and have a time frame. OTs, they help you set the just right challenge because we want you to be successful and then make incremental changes over time. Also, identifying supports and barriers around you can help you make a behavior change. Anticipating any problems or excuses that might come up and problem solving for them before they occur or when they're occurring. Maybe you have a caregiver or a spouse or a family member who can help you work through any challenges so that you can make it part of your daily habit and routine. Performance feedback has also been shown to be helpful in supporting a behavior change. So things like wearing a Fitbit or something that tracks your heart rate can help. And then that tailored instruction from your physical therapist and your OT can also support that behavior change. So some key points for this component is start now if you haven't already. Make it a part of your daily routine. Set a specific goal, identify your supports and motivators, track your progress, make it fun, right? If something is fun, you're more likely to do it. And so explore, go back to that chart Anuja shared and see, what haven't I tried? I've had clients who were never into dance and then they tried it and they're like, you know what? They got really into it. So really you got to figure out what works for you, and that can change over time. I'm going to come back to this later, but I'll share an opportunity, a telehealth opportunity that's designed to help support making a change in your routine. So now we're moving on to stage 2. Symptoms may become a little worse, and this is where we start to see effects on both sides of the body. Changes in walking and moving make daily tasks a little bit more difficult at this point. We're still doing consultative proactive therapy at this point. you're learning more, or your OT and your PT will teach you more about compensatory strategies to address your gait deviations. That's more referring to PT, increasing to address any unsteadiness, to address freezing episodes. At this point, there's still an emphasis on general conditioning, flexibility, and just overall keeping active. Group education with personal rehabilitation is important here. Again, that social component, but also the personalized instruction. And there are studies that show that at this point, skilled therapy, so again, the OTPT is more effective than just a general exercise program. So while it's good to have exercise programs and classes, it's beneficial to then start incorporating a skilled therapist like a PT and an OT. So here's a case example. A client had a tremor and it was impacting his ability to eat, and he couldn't enjoy his favorite foods such as cereal and soup. So what can he do about this? Well, you probably heard of built up utensils. More recently on the market is an anti-tremor spoon. It's really awesome. It has an electric motion sensor to help keep food from falling out of the spoon. So it counteracts the tremor. So there's a video that I'll let you watch on your own time of a woman eating grapes, which is really hard to eat with spoons. I don't know if I'm able even to do it successfully. So if that's something you're struggling with, it's worth checking out some of those products. Ways to modify cooking can be helpful. Simply just having a weighted utensil or something that's heavier can help steady your hand. So if you don't have the anti-tremor spoon or for some other kind of utensil, if it's a heavier, more built up handle, that can help you with stability. Also just utilizing those gadgets that are out there that are big, like this big potato peeler. It's more ergonomic and helpful. You might also want to try using foam grip, just different creative ways to build up a handlebar. Different ways of cutting, like a rocker knife, can also provide more stability. This is like a nice way to chop things. It's easy. Even just like different modifications of plates that have a lip. These are all little simple hacks that can, really change someone's quality in an ADL, such as cooking or meal prep. Along with that, something to consider that you're probably already aware of, but your OT can also help you in terms of scheduling, is medication management and meal planning. So we know that with levodopa medications, it's recommended to take it 20 to 30 minutes before meals because of that, amino acid protein affecting the way the medication's absorbed. And of course, staying hydrated is really important.
So since we're on the topic of medication management, I wanted to point out this excellent resource that the PD Foundation has come up with. So shockingly, 3 out of 4 people with Parkinson's do not receive their medications on time when they're admitted in the hospital. And so this can cause a cascade of events such as falls, hospital-acquired delirium, worsening of symptoms, and potentially a rehab stay that could have been avoided if the medication timing had been correct. So the PD Foundation has come up with this Aware in Care Hospital Safety Kit. You can go to their website. I think some of it's free that you can just order and they'll send it to you, or you can print out. And it includes an action plan and a care fact sheet, which has information about like contraindicated medications related to Parkinson's and the medications that you might be taking due to Parkinson's. And you can give that to your hospital providers so that it's a lot more clear cut, and hopefully they're more proactive about making sure that you get your medications on time.
Great resource. All right, moving on to stage 3. This is when we start looking at more restorative types of therapy. So this is when you might be doing 2 to 4 visits a week for more than 4 weeks. So the focus here is on fall prevention and safety, because at this stage, we're starting to see a little more loss of balance, movement might become more slow, and that might make falls more common. Symptoms also might start to significantly affect daily living activities. So again, the focus here is on that fall prevention and safety, education on compensatory strategies to reduce your fall risk, and then the continued education, and then continued exercise engagement. But now it's going to be maybe modified or look a little different. But again, focusing on strength, flexibility, endurance. We also might be involving the caregiver a little more here on educating on ways they can help. And then continuing to manage the routine, right? Meal, moving, and what is your mood? So when we look at fall risk, we might ask, why are people living with Parkinson's at a higher risk of falls? Well, there are a number of things like motor symptoms, stiff muscles, freezing, balance impairment, and a PT also can be very helpful in addressing that.
So there are various reasons why people with Parkinson's are at a higher risk of falling. The first is that because of its effect on neurobasal ganglia, which is responsible for those smooth, controlled movements, the ability for your brain to carry out reactions to maintain balance decreases. And then the second reason is attributed to the fact that when muscle stiffness increases, muscles aren't able to work at their optimal level. And this leads to imbalance, weakness, decreased flexibility, and all of those will contribute to the likelihood of increased falls. The third reason is age. So most people with Parkinson's are diagnosed after the age of 60. And in general, whether you have Parkinson's or not, as you age, the risk of you falling increases due to decreased muscle mass, impaired sensation, and decreased reaction time. And then freezing or being stuck in one place can contribute to fall. So freezing of gait. So you might experience freezing, you might experience shuffling gait patterns or slowed movement. And all of those can contribute to falls, especially when you're turning or you're trying to walk immediately after standing up. Orthostatic hypotension is a big one, and we'll talk about that further on in the slides, but this can cause a sudden drop in blood pressure, which can make a person feel dizzy or faint, causing them to fall. And then incontinence, especially at night, we'll talk a little bit about this later on as well. Many people fall when they're rushing to the bathroom at night. And so that's something that we can address from a PT perspective.
And OT might help you make modifications to your home, such as removing things like throw rugs that might be a tripping hazard, looking at your pathways, making sure they're wide enough, adding non-skid mats and those grab bars around the shower and bathtub. They're very helpful in case there's a slip or a fall that we're not grabbing on a towel rack. Using a walking aid also can help. PTs are really helpful there in getting the correct walking aid for you as well, whether it's a single point cane or a 4-point cane or four-wheeled walker, just depends on what your specific needs are. And then overcoming freezing episodes, which we'll cover in a bit. And then finally, exercise. That balance training that we talked about from the beginning is really helpful in keeping your body trained to respond better to when you have a loss of balance.
All right, so let's talk about what orthostatic hypotension is. So it's essentially a drop in blood pressure when you're changing positions, such as you're moving from a sitting to a standing position, or a laying down to a sitting position, and your body is not able to recalibrate fast enough to get your blood pressure up when you're moving against these gravity positions. So it's also a non-motor symptom of Parkinson's disease that people can experience. It can cause lightheadedness, dizziness, which can again result in passing out. It can also result in fatigue and nausea. And then eventually it might contribute to your gait instability and falls. So low blood pressure can also happen regardless of having Parkinson's. It could be dehydrated. You could be taking medications that can cause you to have low blood pressure. You can also have like a low blood count or an infection. So it's important to figure out whether or not your dizziness and nausea is really related to orthostatic hypotension or other factors as well. Specifically for patients who have Parkinson's, there's also neurogenic orthostatic hypotension, which might be the culprit. And so that's when your autonomic nervous system, which is what usually regulates your blood pressure during those postural changes, fails to do so because of a chemical that isn't getting released into the body. So it can also happen when you have increased time being sedentary, when your body's used to being in a position where you're maybe sitting on the couch for long periods of time or laying in bed for long periods of time. When you come up to that upright position, your body's not used to that, and it takes more time for it to calibrate again, takes more time for your body to get that blood pressure up. And then oftentimes when you're sitting for a long period of time, the blood pools down into your ankles, and it makes it harder for your muscles to work effectively once you try to stand up. And it's harder for the muscles then to pump that blood back to your body. So doctors will look for orthostatic hypotension, or even therapists can check on this when you're there during a visit. And what they'll do is they'll take your blood pressure when you're laying down, when you're sitting, and when you're standing. And then doctors might order other blood or urine tests to see if those could be contributing factors. So there are several ways that you can address orthostatic hypotension. The first is to check, are you drinking enough fluids during the day? Again, double check with your doctor about this depending on your medications, but it's recommended that you drink at least 1 to 2 liters of water a day. And so you want to make sure that you're getting enough hydration in. You also want to check on your medications. Are there any, look at your list, maybe take it to your next checkup appointment and say, like, are there any medications on this that could be lowering my blood pressure? Is there something that I need to check out for? Make sure to get up and move. That's going to help. The more often you get up and move, the better your body is at calibrating and making sure that you get that blood flow back. And so you don't want to spend a lot of time sitting. Another good idea is doing ankle pumps or knee raises before you get up to walk, so that your body's already getting the signals that, okay, it's time for me to get some movement. I need to get it's helping also to bring that blood flow back to your heart. And take your time when you're changing positions. A lot of times we're rushing. We want to just jump out of bed. And that can, again, it doesn't give your body enough time to get blood flow back to the heart. And so making sure to take your time, staying in the same position for a couple of minutes before sitting or standing helps. And then if you have situations where you have to sit for a long amount of time, like car rides or flights, you can also use compression stockings to help keep that blood flow up. So freezing of gait. Freezing of gait is characterized by this sudden and brief episodes of difficulty bringing one foot forward. And it usually happens when a person is either crossing a threshold, like a doorway, or turning. Currently, the mechanism for why this occurs in people who have Parkinson's is not very clear, and there aren't any medications to treat it. And when the freezing occurs, it's fairly unpredictable, and it's also difficult to elicit. So this makes it a little bit harder to treat. But what we do know is that anxiety, fear, or any kind of stressful environment, oftentimes like a crowded place, can make the freezing worse. And we'll talk a little bit more about how to address it.
So one thing that we can do is cueing. Maybe you've experienced freezing before, and maybe you've heard of cueing. We have what we call intrinsic cues and extrinsic cues. So it's kind of self-explanatory. So I'll start with the extrinsic, having a visual cue like floor markers. There's tape that you can tape. So like Anuja said, doorway. So maybe there's a particular spot in your home that you notice you have more freezing episodes. You might want to try different cues there, like floor markers. I've heard from other clients that using cue cards can help them. Laser lights, which I'll show you some examples coming up. Anything where you're having to step over it. Auditory cues like metronome or music. I have another video example I'll show you in a moment. And intrinsic cues like Anuja mentioned, thinking about what's your emotional set, what's your attitude. That can help if you try to de-stress and get in a positive mindset, that can really help. Mental rehearsal, so slowing down, pausing, and mentally rehearsing the action that you want to carry out can also help you overcome a freezing episode. Internal dialogue, so thinking I'm going to take a big step, an exaggerated step, that can help break it. And then visualizing or imagining someone else doing it can also help break it. So there are a lot of different kinds of cues, and some work for you, some don't. And sometimes it changes over time. So it's worth exploring and seeing what works for you and sticking with it until you need to try something new. So yeah, so with the line placing on the floor, you can use it in different ways. So again, it's individual. One is you can try to place your foot on the marker. So you can use painter's tape or something that's not going to be a tripping hazard. And you can put it at equal distance apart in areas in your home where you think you freeze or you notice you freeze. Another way to do it is to step over the line. So you're looking at trying to step over that marker as if it's an obstacle. And those have been shown to be helpful. So again, you got to just explore and see what works for you. Skimming can also be helpful with other things. So again, we think about how the motor planning is interrupted in Parkinson's. That automaticity of movement is interrupted. So sometimes just breaking down the sequences, the steps that are involved in a total action can be very helpful. So something like sit to stand, it sounds really simple, but sometimes, if we lose the automaticity, we have to break it down so that we can do it and have more independence. So this is something that's great with caregivers as well, as someone's later in the disease stage is having this and doing verbal cues. So simply breaking it down. So moving the bottom to the front of the seat, placing feet flat on the floor, close to the chair and slightly apart, putting hands in a position ready to push, leaning forward, nose over toe is really key. Maybe you're gonna rock 1, 2, 3 and up. This change in positioning can make all the difference when it comes to transferring from sit to stand or from a chair to a wheelchair. So another one to keep in handy. But these types of breakdowns and tasks can be applied to a lot of activities as well. And this relates to another way of approaching activities.
So dual task, simply put, dual task is the ability to do 2 tasks at once. So for example, walking and talking. And the ability to dual task is a reflection of a person's higher level of cognitive function, because you have to place your attention to both the cognitive aspect, so talking, for example, and the motor aspect, like walking. So for a person who has Parkinson's disease with the progression of PD, like Katrina said, that automaticity of movement starts to decrease. And essentially what you're used to being an automatic task now requires thought and increased attention. So studies have shown that Parkinson's disease affects a person's cognition, especially in the areas of attending to a task and higher level executive functioning. So when someone with Parkinson's needs to participate in a dual task activity, they now need to pay more attention to the motor task, like walking, as well as continue to put in effort into the cognitive task, like talking. So the brain often ends up having to prioritize which one it wants to focus on. And typically it ends up prioritizing the cognitive task, which means that clinically your motor task is more affected. So it might look like you have a slower walking speed, your step lengths might vary, you might have decreased balance, which can then lead to more falls. So strategies to improve dual task in the early stages, you want to incorporate those higher level cognitive tasks while you're participating or practicing in a dynamic balance or walking activity. So this helps your brain get used to managing those 2 tasks at once. There's a really cool app called the Clock Yourself app, and it's a fun way to do this. So it gives you these exercises while you do cognitive tasks. So that's something that you can look into. I have tips on how to address dual task in the mid and late stages later on in the slides for you.
Did you say clock yourself, Anusha?
Yes.
Thank you. And I'll give you guys a quick 35-minute time check. You're doing great. Keep it up.
Okay, thanks, Todd.
I also wanted to say there was a question, and I'm curious because it seems like you are both very specific about Parkinson's and the PT and OT related to Parkinson's. Someone asked what's the difference between someone who's certified in Parkinson's PT, OT versus someone who's not? Is it different for Parkinson's OT, PT?
I'll let Anuja answer for PT.
So, I would say yes, there is a difference. There's no formal certification on getting certified for Parkinson's. There you might have certifications in Parkinson's related exercise programs like LSVT Big or Power, or from a PT perspective, you might find might be able to have your neurological clinical specialist certification, which will give you you really go in depth into neurological clinical conditions, which includes Parkinson's. So ideally, when you're looking for a physical therapist and it's related to Parkinson's specific challenges that you might be facing, you might want to check and see, does my therapist have a neurological clinical certification, specialist certification? That being said, just because you have Parkinson's doesn't mean that you won't have a frozen shoulder, or might not need a knee replacement or have knee pain, so you might have other orthopedic conditions that aren't necessarily related, but Parkinson's still affects that, right? And so you want to look for a therapist who might have experience treating Parkinson's. They have an idea, so that when they're treating you, maybe for another issue that you have, they still know that this is what's going on in the background, and that will affect your movement. Does that answer the question?
Yeah, that's great. Thank you.
Yeah, and then for OT as well, there's no special PD certification. However, you can, there are generalist OTs and specialist OTs and generalist OTs. So there might, ideally find someone who has experience with Parkinson's disease. However, OTs are trained to do task analysis and assessments. So yeah, just like any profession, if someone has experience, it's better. Or you can give them an opportunity to learn.
Seems like it's a discipline that deserves certification out there, I would think, but maybe that's coming.
Yeah. Yeah, certainly. There's a lot to learn about Parkinson's for sure. Okay, so more compensatory strategies. When we think about motor challenges, you might have experienced difficulty initiating movement. So a strategy would be to think about preparing the movement in advance. So this is where you think about that cortical activation of the brain. So when you have motor imagery or visualization, you're activating the brain, so you're preparing to do it. That can help you with the initiation difficulty. If you're having difficulty with sequencing movements, this is where breaking down the complex motor task into individual components, like with the sit to stand example, you can do that with various activities, just break it down. If you're having difficulty with that dual task, like Anuja mentioned, you might just want to avoid the simultaneous motor activities or the motor with the cognitive activity. That can help you complete an activity and be safe, especially when we think about a fall risk. So focusing your attention on the voluntary control of a single task, one task at a time. If you're having trouble with self-initiated movement, this is where having external cues can be helpful. So again, when we think about freezing, whether it's visual, auditory, that can help you start or maintain an activity. If you're having difficulty manipulating objects, so using larger targets can help facilitate movements. And then finally, freezing, again, looking at what's your environment, how can you set up the environment to support you and reduce freezing episodes.
All right, so let's talk about incontinence. I feel like this is a challenge that many people face, and we don't talk about it enough. And so I wanted to make sure that we included this in our slides. So urinary incontinence is the loss of bladder control, where urine leaks before the person's able to reach the bathroom. And millions of people experience this, especially as they get older. So some might experience stress incontinence, where you lose drops of urine during laughing, coughing, or exercise. And others might experience urge incontinence, where you feel like a sudden need to go to urinate and you aren't able to control it until you get to the, and before you get to the bathroom. So some people might even experience a combination of both. Incontinence can happen at any time, but many times it happens at night, especially as you age, and feel the urge to go more frequently. And this is dangerous because falls often happen at night when someone's rushing to the bathroom, like I mentioned before. So it's important that we, address this to try to decrease maybe the amount of times you're going to the bathroom at night, or might be other strategies that we can do in terms of home modifications to light up the room and your home better to get you to the bathroom more safely. So in terms of how this is really related to people who have Parkinson's, the changes in the dopamine levels can affect your bladder control. And sometimes those disruptions to the signals from the brain to the bladder can occur, which increases your urinary frequency. And then we'll talk about treatment options in the next slide. So the first thing is that it might be helpful to see a pelvic floor specific PT. So I saw that 4% of you also said you had challenges with intimacy in the last poll. And so a pelvic floor PT or even just any PT can help you with some of these challenges that you might have. Pelvic floor PTs are trained to address incontinence as well as help you retrain your bladder. And oftentimes it's just simple behavioral changes like diet modifications and creating a routine that can help you significantly. Your pelvic floor PT can also help you learn strategies to decrease the urge to urinate if needed. And recently, for people in the mid to later stages of PD, the use of a transcutaneous electrical nerve stimulation device has been shown to effectively treat an overactive bladder, specifically for people with PD. So that's an interesting thing that's coming out in the research. And that's something, again, that you would want to talk to your PT about or your urologist about. And then lastly, just generally having a strong and coordinated pelvic floor helps. And so your PT can help you with that as well.
All right, next we're moving to stage 4 and 5. And again, not everyone progresses to this stage, but it is considered the last stages on the Hoehn-Yahr scale. And this is where we have the skilled maintenance coming into play. So there's an emphasis really on caregiver education here. And again, safety. This is where assistance with transfers, bed mobility, ambulation, exercise is important. And we'll still be incorporating exercise, but it's mainly aimed at maximizing flexibility for those ADLs and mobility with your caregiver. So here it's about one visit every 1 to 3 weeks and ongoing through the months. So again, freezing of gait, you're gonna be maybe trying different cues at this point. I mentioned the laser light before, so maybe if you're using a walker, there are walkers with the laser light. So it's that visual cue to try to step over the light. There are some walkers that have the auditory cue as well. And then as well, thinking about those intrinsic cues and what's helpful. This is an excellent video. I don't know, do we have time to watch a few minutes of it? If not, you can come back to it. It's of a gentleman. And he's walking with his,
Katrina.
What'd you say?
Sure, give it a go.
Okay, I'll play a little bit. So you'll see him walking without the cue and then with the cue. Can you hear it?
We can't hear her.
Oh, I'm sorry. I think we have to enable the audio. So maybe you'll have to watch this on your own time.
Okay.
It's a Zoom glitch. But yeah, so basically I can just explain to you when you go watch this. He really struggles to walk. He's freezing. He's really leaning. His trunk is forward and he's dragging on that walker. And then she plays him a song that he likes and he gets the rhythm. And then he starts walking with no problem. And then he leaves the walker and then he's dancing. So it's really remarkable the difference it can make with the auditory cue. So definitely watch this on your own time. I get goosebumps and I get tears in my eyes every time I see it. It's really amazing.
That's great.
Okay, so now I'm going to let Anuja discuss some summary tips for those 3 main Parkinson's features.
All right, so this is something that you can look at and refer to as well. I think you'll have the slides, but I just created some summary tips and they're based on the early, mid, and late stages of Parkinson's and how you can address these challenges that you might face during each stage. So during the early stages, again, we want to focus on just general wellness and strength, really looking at dynamic and reactive balance activities. So you can start that early on in the disease stage. And also you want to make exercise a habit, like Katrina mentioned. So that's going to be really, really important. During the mid stages, you want to make sure to practice fall recovery in case it does happen, making sure to know, how do I get myself up? Who do I call? What do I do? And having that action plan. You want to continue to work on balance, monitor and check your vision. As you age, you might have vision changes, and that can also affect your balance and your walking. You want to make sure to check for any blood pressure changes, and then you might want to start practicing utilizing an assistive device. You might not need it at this stage. Hopefully you don't, if you've done all these things in the early stages. But getting that motor pattern of utilizing an assistive device oftentimes helps you in the later stages, because you don't have to relearn or learn a new thing in the later stages of the disease process. Later in the late stages, don't be afraid to use an assistive device for balance. I see this really, really often. People just don't want to use that walker or that cane. And truly, it's not a matter of ego or anything. So please don't be afraid to use it. You might want to address any incontinence if there is. And like Katrina says, you really want to just maintain your functional mobility and flexibility, and also continue to challenge your balance so that you continue to maintain your balance as well. In terms of dual task activity, in the early stages, like I said, you want to practice that higher level cognitive task while you're practicing dynamic balance or walking. And what's really important, really, I put this in the early stage, but it's important in the early, mid, and late stages, is to continue to challenge yourself, right? If there's no challenge, there's no change. And so I know that sometimes the tendency is like, you want it to be easy, but if it's easy, then it's not really doing anything. So just make sure that you are challenging yourself. In the mid stage, you want to make sure to maintain your neck flexibility. I know that sounds kind of interesting and maybe something you don't think of, but in order to do a dual task such as scanning the environment or looking up and down, you want to make sure that you have that range of motion in your neck, because if you don't, that makes it even harder. And again, you want to continue to practice those balance with cognitive tasks. And then in the later stages, you might need to shift your focus on practicing more of that automatic movement, things that come easier typically to you with the cognitive task, or focus on one task at a time. And then with freezing of gait, I know we spoke a lot about this already. So in the early stage, you want to practice utilizing those internal cues to yourself, taking larger, telling yourself big steps, telling yourself, any kind of large amplitude movement that will help. The other thing that people don't often realize is you want to look at trunk rotation. So that's something that with Parkinson's, because of the rigidity, you start to lose earlier than other aspects of your mobility. And so if you can maintain that trunk rotation, that's shown to actually help with freezing of gait and decrease that freezing. In the mid stages, you want to use both internal and external cues. You want to make sure to warm up prior to walking. So maybe doing ankle pumps, knee raises before you stand up. Once you stand, start to do some marching before you start walking immediately. That helps to get your body moving and just telling it like, okay, time to work now. And again, you want to practice those large amplitude movements. That helps you take that big step to get over the doorway. Taking larger turns will help you to, decrease the shuffling and the freezing. So those are just some things to think about. And then in the later stages of the disease, you might find that you're using those external cues, like Katrina said, more, and you want to continue to utilize those large amplitude movements.
Excellent. All right, so I want to give a shout out now to a research opportunity if you're interested. It's a telehealth program looking at improving self-management of a physical activity routine. So we talked about how sometimes making that shift of increasing exercise can be hard. So this intervention was designed to help support you in that. So it's client-centered, one-on-one with a therapist to set goals. If you're interested, I have some contact information here, or you can email me directly. I have my email on the last slide, but this is sponsored by the Michael J. Fox Foundation and the American OT Foundation. And I'm the study that I'm doing at San Jose State University in collaboration with Columbia University's Neuro Rehab Lab. Yeah, so there's the timeline. If you're interested, it's a 6-month commitment. There are 2 groups. So there's an education group and an occupational therapy group. If you get in the occupational therapy group, you get a Fitbit that you get to keep, and you get these therapy sessions. If you don't get in that group, you can still participate in the intervention after you've completed the education group. And basically, we just look at your physical activity and was there a change in your physical activity, and you do a couple questionnaires. So yeah, if you're interested, it's also in Spanish. So if you have any friends who Spanish is their first language, we have the resources there to support you, and the flyer information is in Spanish as well.
This is great. We have a brand new Spanish speaking support group that we can print that out for them and have it at the ready.
Excellent. All right. I also have some references if you're interested in looking at particular studies that Anuja and I referenced. Otherwise, we're happy to answer your questions.
That is great, Katrina and Anuja. Thank you very much. That is definitely one packed slide presentation you got there. Lots of good information, and you did it very well. Thank you. We will start to field questions now, and a couple have come in through chat. A couple have come in through my own email too, as well, which I'll refer back to in a minute here. But just a reminder that if you have questions for Anuja or Katrina, lob those into the chat window, and Kathy and I will pick those up when they come in. Emailed to me was a question, in fact, 2 emails, both of them are sort of, I can relate to. One addresses the concept of her degraded posture. She's worried about her shoulders stooping more and more and more. Her back has been hurting lately, her lower back, and she wants to know what she can do to start to sort of prevent any further degradation in the stooping, and is this just a function of just sort of core muscle improvement?
So I can take this one. I think that it's great that she's realizing that this is happening and wants to address it, because I think the earlier you address this, the better. So the stooped posture and that forward flexed posture is a major clinical sign of Parkinson's, right? And so, like I mentioned, I think that strength training is a great way to really help to improve, get that upright posture. You want to focus on what we call the posterior chain. So the back muscles, the back, your glutes, anything around the back part of your body, you want to try to work on strengthening that area and then stretching out the front area of your body to help you with that improved posture. So I'm not sure what she looks like. I'm not sure if she has any other kind of musculoskeletal challenges that she might need to have addressed. So I would really recommend that she goes to a physical therapist. It might not be that she needs to go frequently, but at least to get an evaluation, get some exercises, and get those check-ins while she, does her exercises to improve that posture.
Good. Okay. A good question coming in from Stephen. How does DBS impact gait and balance? Should I expect vast improvements? I'm taking it Stephen has or probably has not had DBS yet, but can you speak to that?
Yeah, so this is another very common question. The research on it is honestly varied. So I've seen people who have with the DBS, maybe their other motor symptoms of Parkinson's have improved, but their balance, I wouldn't say it gets worse because of the DBS. It might just be the progression of the disease, and they haven't addressed it with exercise. But I've also seen the opposite. I've seen that, patients have told me after my DBS, my balance got a lot better, my gait got a lot better. So it's really hard to say. What I will tell you that might be beneficial, if you really want to get an objective idea, is before going into the DBS, get a PT evaluation. Ask them to do objective measures that are related to Parkinson's. Ask them to check your gait speed. Ask them to check, we have a 5 times sit to stand outcome measure that they can time. You can do a timed up and go, just so that you have these objective numbers of how you were doing before the DBS. And then after you get the DBS put in and after you get clearance from your neurosurgeon, you can then go back to PT and have them check those outcome measures again, and then periodically check them to see how your progression is. I also would recommend that, I think a lot of times people think, oh, I got this DBS, that's all I need. I don't need to do exercise. I don't need to, make this habit of exercise. And that's completely incorrect. So you want to still have an exercise routine, making exercise a habit, despite having this DBS or getting a DBS.
Yeah, I just want to add to that, just like an adult aging without Parkinson's, exercise is still important. So we all need to be doing these things. It's just even more beneficial for someone who has Parkinson's in terms of having an effect on their disease.
Great. Another email that came in, and another topic near and dear to me, is the combination of writing and typing. Katrina, I didn't see too much in the presentation, but I can speak for myself and say that my typing has gone horribly downhill to the point where I'm now typing with one hand, my good hand. Writing is completely illegible. Is there anything out there you can tell us to work on? Any tools, any tricks?
Yeah, so one thing I saw, and I ended up taking it out because I didn't see it on the market yet, but I know Columbia was doing a study on it as well. There's something called an Emma Watch, which was providing a cue, and it was helping improve someone's writing who had a tremor. Maybe we'll see it on the market. I don't know if it's effective for everyone. And then in terms of like typing, just thinking of, this is where the OT would discern, are we going to teach you a compensatory technique, or are we going to try to remediate what's going on? And a lot of times, sometimes the compensatory technique is the best approach. So if typing is so much a struggle that you're not able to continue in that occupation, you might need to look into an alternative like voice to text dictation, where it's taking out the typing, but you're still able to engage in that occupation of putting words into a computer text. And then in terms of writing, certain hand stretching activities, I could find some links to share with you if you're, having that tightness in your hands, and range of motion exercises can be helpful as well.
Good. I'm glad you mentioned talk to type, because I use it religiously. For those that out there don't know what that is, there's usually a utility built into your operating system that allows you to push a certain button on your keyboard to activate the microphone so that you can speak into it, and it translates those into written text, almost regardless of which app you're in, whether it's Microsoft Word or text, like Katrina said. So check that out if you don't know about it. Let's see. So Stephen just asked, are there voice to text apps you recommend? So I mentioned the fact that there's a utility in most operating systems. I know I use Mac, and I can double tap on the FN key, the function key, and that brings up my microphone, and I can start talking into my computer, and it transfers that into text. If you want to get out into the commercial space, there's Dragon Type, one of those two. And there's probably a handful of others. If you Google text to type or talk to type rather, you'll probably find those in the results.
Yeah, and if you have a Mac, a lot of Mac computers have the function, you double press function. And yeah. Did you mention that?
Yeah, it's very helpful. Very, very
Yeah.
helpful. I use it religiously. I mean, I go back, I basically will talk a whole paragraph, and then I'll go back and take just 5 to 10 seconds to fix the minor mistakes. But I
use it too.
About 90% accurate in my estimation. Very helpful. Let's see. Ingrid has a question. I will just read it out here. I find exercise classes such as yoga or dance very tiring and ultimately too stressful as my PD progresses. So there's not really a question in here, but a comment. But how would you suggest that we combat the fatigue that comes with some of all of this exercise, the weightlifting, the balance, the cardio, etc.? I can relate.
Yeah, so actually fatigue related to Parkinson's disease is a major challenge that many people have. And, it's so subjective and so unique to each individual as to what causes the fatigue. But what I will say is that there are a couple of strategies in terms of energy conservation that you can utilize to try to combat this. So, making sure to take rest breaks throughout the day. If you feel like a certain exercise is really tiring, think about like, am I doing it for an hour? And that's why it's really tiring. Can I maybe only do it for 30 minutes and, do the other 30 minutes another day? Another, thing to think about is to look at the role of anxiety and depression and that relating to fatigue. Oftentimes there's that physical fatigue and then there's a mental fatigue, and you trying to decipher the two is important, and making sure to understand, like, am I getting tired because of the exercise, or am I having this mental fatigue that's then coming into the rest of my daily activities? So but an easy way to just kind of think about and start this is to try to conserve that energy throughout the day, and maybe do short spurts of exercise instead of longer.
Great. Any other questions out there, folks? If you would like to just ask your question straight up and not type it into the chat, that's absolutely acceptable as well. You can just show us your hand or use the raise hand feature in Zoom and take yourself off mute. We'd love to hear from you. Kathy, did I see your hand go up?
Yes, I see that somebody asked about PT for a specialty in pelvic floor exercises, or do all PTs have experience with this? That was one of our members' questions.
So it depends on the situation, but I think that just like what we talked about in terms of someone who has Parkinson's and finding someone with experience, when you're looking for a PT, I would recommend that you try to find someone who has experience with the pelvic floor. I think more and more PTs are educating themselves on the pelvic floor and its role and its effect on the entire body system. But I do think that there are quite a few people PTs out there who are still not as experienced or don't have that knowledge. So ideally, if you're having trouble with anything related to the pelvic floor, if you're having trouble with incontinence, intimacy, any kind of like prolapse for women, you want to try to find a pelvic floor specific PT.
Excellent.
There are, if you're having trouble finding one area, you might look into OTs. There are some OTs that become pelvic floor specialists as well.
Okay, great. I didn't know that.
Still looking for any questions or hands raised.
I was actually wondering, how can people practice safely falling? I know that's been an issue for a lot of our members, and I know that some instructors do that in their classes, but not everyone knows how to do that or how to practice that. So what would you recommend to do it safely, of course?
That's a great question. So one thing that you can do is go to a PT, because oftentimes, if you go to a PT clinic, they have special mats that are soft, that they can help you get down onto the floor and then teach you how to get back up from the floor. And so that's a very safe environment where you have other people around you in case that you need to get up. You might need, and you need additional assistance, they're there for you. In the ideal world, you have a overhead hanging harness on you, and then you can fall and get back up. And some clinics are starting to have that now, but it's still pretty rare. I I don't know anyone in the Bay Area specifically that has it yet. But I still think even just going to, having a PT, scheduling a session with a physical therapist and saying like, this is my goal. I want to learn how to fall and I want to learn how to get back up safely. And they can help address that.
Okay, great.
That's probably really important. Stephen, I see a question.
Yeah, I have a question. I'm going to have a knee replacement and probably do deep brain stimulation. I have yet to find a good physical therapist that I've been able to work with the Parkinson's, and I had a frozen shoulder. How would you suggest locating a physical therapist?
Good question, Stephen.
That's a really good question. So I think it's the APTA. If not, it's the Academy of Specialized. So it's, if you look up how to find physical therapist NCS or neurological clinical specialist, there's a directory online that has all therapists who have their neurological clinical specialist certification and where they're located. So that's a good place to start. As somebody who has their NCS, has a background in general physical therapy, but also has that additional experience with the neurological population. And so you can go in that route. It's in the Bay Area, you can also look up like neurological physical therapists, and oftentimes you'll find clinics in the Bay Area, depending on where you are, that would have therapists who have that experience as well. And the other option is that if you for example, and you might have already tried this, but like if you're going to get your knee replacement and you're planning on going to a PT clinic, you can call and say, are any of your therapists, do they have experience working with people who have Parkinson's? Don't be afraid to call. Like Katrina said, be an advocate for yourself and say, like, I have Parkinson's and I want someone who has experience with that to treat me, and see if they can help, set you up with someone.
The tendency is that they all say that they have some experience, but I haven't found anyone that really has.
I'm sorry, that's really frustrating.
Yeah, it's.
Try Googling that, Stephen, the NCS neurological clinical.
Yeah, that's a good idea. Thank you.
Yeah.
Yeah, I put a link in the chat. It's the Professional Resources Neurologic Specialist. Is that the website you were talking about?
Yeah, I think so. Oops.
Academy of Neurologic Physical Therapy? Okay,
Yes,
great.
That's it. Mm-hmm.
Thank you. That's very helpful.
Yeah.
A question on gait. This one's coming from me. Maybe others can relate. It's been frustrating me that when I go on my power walks, I'll call them, with my wife, my left leg drags. So the heel, as I'm stepping forward with my left foot, drags, and it takes me all kinds of concentration so that I'm swinging both arms for one. My left leg is really reaching out and going heel to toe. Are there any specific exercises I can focus on to try to get my gait more even?
So one kind of idea that I have that I utilize often is that you want to practice that task specifically. So we call it task specific practice. And so, what you can do is you can break down. So if you're having, break down the task. So if you're having difficulty getting, your toe up as you come through, is that what's happening? I'm assuming.
Yes.
Right. What you can do is during your spare time throughout the day, just work on bringing your toe up. When you're sitting, doing work at the computer, work on bringing your toe up. When you're standing and maybe, watching TV, work on standing at your step and just getting that toe up to land on the step. So you just keep getting the practice of actually doing that motion, and that helps it to become a more automatic task. It'll help to strengthen and create that, more than strengthen, but it'll help to improve that coordination, sending that message from your brain down to your toe to say, I've got to pick up my toe when I'm swinging. And that will help make the task more automatic as well. So you feel like you don't have to think about it as much. The other thing is, are you talking to yourself when you're walking? Are you telling yourself toe up?
Yeah, I have this little mantra that I do, which is swing, swing, heel toe, long strides, upright. So I've got it rhythmically by step. So I'm focusing on getting the swing going, that I'm doing heel to toe, and that I'm taking long steps and I'm standing upright instead of hunching.
That's great. And then the other question I would have for you is like, do you have a strengthening routine put into place? Are you working on, balance exercises? Do you have any gaps in your exercise routine, like utilizing that chart that we put out?
Yeah, I do. Thanks for that. Thanks to that chart, I'm now realizing where my gaps are, mostly in the weights category. I mean, and weights and balance, but mine have focused on cardio because I've been everything I've ever read that I can remember has said, the key to keeping your PD symptoms from progressing is to do exercise 5 days a week, 40 minutes at a time, cardio as much as you can, as hard as you can go.
Yeah. And so, we typically recommend like 150 hours a week of moderate to intense exercise. And that looks moderate to, say that again, sorry.
150 hours or minutes?
Minutes, I'm sorry, minutes a week. And what that moderate intensity exercise looks like is different for everyone. And so, that's what I say, getting an activity coach or a physical therapist to help you set up that routine can be really helpful and talk to you about a lot of these things. But yes, having that well-rounded, you want to make sure to also address the strength and balance, because that will also help with your ankle. It'll help with your foot strategy. It'll help with a lot of things that are related to your walking. So I would suggest that's another step to take as well.
Good.
Yeah.
I just want to add to, sorry, I just wanted to add to that. In terms of the research and exercise in Parkinson's, surely there is an emphasis on aerobic because it is important, but also every exercise that was listed in that table was supported by a PD specific study. So there are other studies that show why it's beneficial. And again, we think about the body aging, and even people with outside of Parkinson's, it is important to, again, have that holistic program to support a healthy aging body.
Excellent. One thing I wanted to also add is that one of our members mentioned Otto, and Otto is our instructor for a Tai Chi gait and balance class. And so that is also offered at PD Active. And so I just wanted to make sure that everyone knows that that's an option if you are having balance or gait struggles. And then I wanted to make sure Todd sees that someone recommended that their PD suggested a fitted orthotic to help with the front of the foot dropping. And it was fitted at UCSF, and apparently it made walking amazing. So
that's interesting.
Yeah, thank you, Jerry, and thank you, Karen.
I'm a proponent of orthotics, but I didn't know that there were specific orthotics to help things like what Anuja was explaining, getting the toe up. Yeah, thanks, Karen. Did I see you raise your hand, Karen, for another question? You're muted, so take yourself off mute first.
Yeah, that was a masterful interpretation of a one-word message. My finger went awry after the Otto. So I just wanted to say, you mostly said it for me, but I wanted to add that I think Otto really works on that specific motion control, and over and over and over you do certain movements, and it's boring as all get out, but I think it works.
Mm-hmm. He's very good. If folks here have not tried Otto's Tai Chi for gait and balance class, it's terrific. I need to get back to it myself. Let's see, any other questions? We're coming near the end of our window here, but I don't see any others. Kathy, did I miss any? No.
Will you guys post that the brochure on the study they talked about at the end.
Sure. Yeah. Katrina, when you have a minute, if you don't mind sending me a standalone PDF instead of me copying it out of the deck, that would be great. And then we'll post that, Karen, on the site. Kathy also has a good spot on the site where we will post the whole PowerPoint deck. As I mentioned at the top of the presentation, the doctors are fine with us posting that. So it's chock full of terrific information, and it's not easy to glean that all as it goes flying by you in a short window like that. So we will post that up there. And again, this whole recording of this presentation will be posted on our YouTube channel. So unless there are, oh wait, I see 2 other messages popped in. Thank you for the workshop. Thank you, Anuja and Katrina, for great info and discussion.
Can I ask how to copy the chat?
Yeah, good for you. That's a great call, Stephen. So if you look at the bottom of your chat window, if you have your chat window open, there is a small 3-button icon, a 3-dot icon. Do you see that tiny little thing? There are 4 or 5 icons at the bottom of my chat window, and the one to the rightmost is a 3-dot icon that if I click on that, the first option at the top of that menu dialog, save chat. You see that, Stephen? Good. Groovy.
All right, and I just put in the link to our Tai Chi for PD. And if you click on that link, you can see we have a regular Tai Chi class and also a Tai Chi for gait and balance as well. And then lots of other exercise programs. I know there was a lot of emphasis on exercise. And so please check out our programs. And if you have any questions, I'm Kathy and I am here to help. So my email and phone number are on the website for PD Active.
And with that, it's time to thank our panelists, Dr. Katrina and Dr. Anuja. Thank you very much. You're 2 very clearly experienced and well-versed in your craft. So we're glad to have had you. And we're glad that even if there's no certification out there in OT or PT land for PD specific folks like us, we're glad that you're so smart in that category. That was a terrific presentation. So thank you very much for your time.
Well,
And
thank you.
And
also, just a shout out, it's PD Awareness Month. So
PD Awareness Month, that's right. All right, folks. Well, we hope you have a wonderful rest of your evening, and thank you for joining us tonight. Bye, all.
Thank you, Todd. Thank you, Kathy. And thank you so much, Anuja.
Thank you.
Thanks,
you,
everyone. Have a great
Bye.
night.